Emery.
Oh, thank you. Any questions yet? Well, if not, we can also answer them at the end again if anybody comes up with anything. So, extended implant indications and off-label. I'm going to show you a few things. And again, I just want you to think about what we're doing with it and how it's used, and you may even come up with other things. So, minimal mouth opening, patients with scleroderma, rheumatoid arthritis, radiated patients. I showed you a radiated patient. I mean, there is no other way to treat these people if you want to guide, and in some cases it's easier to guide with this than it is to do freehand, particularly if you do scleroderma patients, because you can operate on them with their mouth closed. Removal of foreign bodies, screws, and particularly implants. I'm going to show you one of those right away. Osseodensification is a giant thing, and once you do a sinus elevation case with this, you won't use any other technique because it's so easy and fast, and it's so predictable. Root shield and partial root extractions, I think this is going to grow, only because everything else we do, we know over time looks worse. Even some of the stuff that the ITI people are pushing, if you look at the long term, they even have the areas flatten out, and the root shields, I can't do it without guidance. Ridge splitting is pretty easy. It's pretty straightforward. I'm going to show you a different twist on it. Harvesting bone grafts, you can use a trephine. Any of the trephine systems, like the transfer control system, works really well with this. Bone rings, I have some cases cooking in them. So I'm not going to show you any because I don't like showing things that I don't have final results on. But this is something that Straumann is pushing. It's a German technique, and I think guiding it is going to be more predictable. At least in my hands it has been. Distraction osteogenesis is not something I do anymore, but I'm going to show you again a new twist on it, and that you can do with guidance that you couldn't do before, and it may actually answer the problem with it. And then nerve lateralizations, it's used in this case to find the entry points, and we'll talk more about that. So our first case I showed you at the beginning, this case was referred to me. The patient had numbness when the implant on the left was placed, and the right one was failing. The left one also fractured, because again, it's a little distal. And so removing this was problematic. And I'll show you that's why it's problematic. How do I get that out without perforating the floor of the mouth or nailing the nerve? So what I do when I have these kind of cases now is plan the trephine to go just short of what our anatomic structure I'm worried about. In the case down here, I want to make sure that I don't perforate through the floor of the mouth here, so I don't want to get a bleed. And on this side, I want to make sure I'm short of the nerve. So I've mapped the nerve here, and you can see where the implant is. And I'm going to, again, stay just short. The really limiting thing here is the floor of the mouth here. So my osteotomy is just short of there. And so you can't show the implant. I didn't get a video of the implant or the X-guide when it was taken out, but you can see the post-op. I went exactly where I planned it, and this patient was not numb. So I'm just short of the apex, and then I take an instrument and luxate the final part out. Now, what if that piece had broken off? I would have left it. I wouldn't have gone and tried to get it. And I did that on another case recently, and I don't have any pictures to show, but if that little piece breaks off, you just leave it. So this is a new twist on ridge splitting, and this is Raj Bath, is an oral surgeon in Ohio, sent me these images, and I've not tried this technique, but if you were just doing a straightforward ridge split, you just plan these, a series of 2mm twist drills, and you could use a smaller one than that, and you plan them to the depth and the angles you want, and then you just connect the dots with the piezo. You don't have to make any incisions short of just the crest, because you know your angles. Now, right now, to connect the dots, you could use a liniment burr if you wanted. If you made all the dots close enough, and then you could guide the whole time. Once we have a straight handpiece, which is short, in a short order, you'll be able to guide the whole thing, but you could do it right today. Now, this is what Raj does that I think is interesting. He plans an implant in to go to the side, and then he makes a little tiny stab incision right here, and he cuts it loose on the bottom. And I think that's, I don't know if any of you have tried ridge splitting, but how often do you do that and it doesn't break out? And there's even delayed approaches where you make an incision, you cut that horizontal part, close it back up, wait 2 months, and then go and split it out. But since he can guide this horizontal part here, he just does it all at once. And here's his post-op. Now, I haven't tried this, so I'm not going to tell you I've done it, but it's interesting, and this intrigues me. I mean, that's pretty impressive, I think, there. You don't normally see that because how do you cut that? So he cuts it, again, through that little horizontal incision. Made his incision, his osteotomy with under guidance. So, there's supposed to be. I wanted to show you distraction, but I will in a minute. I thought I had that right after that. So, deep bone biopsies. This is easy, and you can do this tomorrow. And I'll show you. Deep bone biopsies, extraction of third molars, and I'll explain how I do this and what I say. Excision of tori. This makes it really straightforward, and I think a little safer. I'm not going to show you an apico because I haven't done any of them in a long time, but I did one with the predicate device. You just plant an implant to the apex and cut a hole. It's not very hard. You can use your implant drills to take the tip of the tooth off. Endo access of calcified canals. Now, these are hopeless teeth. These are teeth you wouldn't be able to treat normally. And I'm going to show you a video of somebody doing that access opening in about 2 minutes. And where normally when he'd try to do it, and he wouldn't even guarantee his patients he could do it, it would take him 45 minutes. And then micro-endo accesses. Again, I don't do endo, but they are doing some really interesting endo approaches to minimize the amount of tooth they destroy. So this patient is going to get an implant here, and then we're going to do a biopsy here. This has gotten bigger over time, and we want to do a biopsy of it. You can see where it is. Now, in the old days, I might have taken this patient to the OR to do this because I don't want to nail the nerve, and it's going up the ramus sometimes can be problematic getting to. And I'm going to do this in my office when I put the implant in. So this is an unedited videotape. And I'm going to show you something right away about this. Now, I planned this initially. You'll see how it's so straight up. Now, guess what's going to happen when I try to put the drill in there? The head of the drill is going to bang into the maxillary teeth, even if the patient opens a mile. So I planned it this way. I started doing it, I realized, oh my goodness, I can't get the drill head in there. What'd I do? I just changed the plan right away. So this is I think it's an interesting place.
This your father.
It's happened to be a priest. So I'm doing a system check on the bone, and this is about 6 millimeters deep.
Come out. Just suction. Let's have a look when it's quiet. I don't know when my drill isn't this quiet all the time. Expose it so I can see.
So what I'm using is my implant drills. And I'm going to go up to 6 millimeters. the biggest drill I have on that system. And then I'm going to scoop this out with curettes.
Come on.
Doing a system check.
Isn't it just easier for you and the father?
So then I just take a curette and scoop it out. And there is that little object. You see that little piece there? There it is. And this just turned out to be a little fiber osseous lesion, no big deal. And then I put the implant in on the other two. Now, I recently had somebody who had a large giant cell tumor on a kid in the posterior ramus, and he wanted to inject it. It was sort of at a weird angle. He just aimed the implant osteotomy, made his holes with that, and then injected it. This is one of the reasons I wanted to get involved with this whole project. And I started this a long time ago with a predicate machine, okay? Because what's the number one reason oral and maxillofacial surgeons in the United States get sued? Numb lips and numb tongues. And why is that? Because we either crush the nerve with the roots, or we cut the nerve and we get a numb lip, or we cut through the lingual cortex with our instruments and we get a numb tongue. And why is that? Because we can't see what we're doing. And we're doing everything based on parallax vision and estimates of where our drills are. What's real hot now? Taking crowns off and leaving the roots. Well, is that easier than extracting the tooth? I'll tell you, taking that crown off without nailing that nerve and not going through the lingual is tough. So this was in last month's Journal of Oral and Maxillofacial Surgery, this paper, and 25 teeth like this or worse, okay? All under guidance. And it reports on, this is a proof of principle that it can be done. Now, all these cases were done in my office. Normally, I would have taken them to the OR. So this is what I do now. Now, this is off-label, and I do it a lot. If I have someone coming in, and they say they're going to have a tooth like this extracted, I'll say, I'd like to use this as a probe. I'm not going to extract it, I'm not going to cut it, because I don't have a drill to cut it yet. Because you can't use a contra angle back there, because the angle goes down when you put it in the back. And so I tell them that I'm going to use it as a probe, and as I cut down, I'll stick it in every once in a while and see where I am. And you can see, in this case, I planned the osteotomy and implant to the lingual cortex, so I know when I get down there. As soon as I get down there, I put it in, and then I start looking at these different views, and you can see where I am in the lingual. I did not cut it through, and there is a micro CT of the post-op. Now, does this make it safer? I can't prove that yet. I will. With time, we're going to do a study on this to get this approved by the FDA. But right now, I can tell the parents of these kids, or I could tell you if you had a tooth impacted, that I believe I'm going to be safer than somebody that doesn't do this, because I know where my drills are going to be. So I'm going to take my time and put the probe in and see my angles. Now, has anybody ever in the world measured how good surgeons are at cutting the way they plan? Until Verkruzian did that study on static guides in freehand, nobody had ever measured how good you were putting in implants. And then we were the second ones to do it in the world. Nobody measured how good you were, or we were, except for on models. Nobody's ever measured how good oral surgeons are at planning and executing their third molars. And we're going to do that. And my prediction is we're going to find out we're about as good at that as we are at putting in implants. And I think we can make it safer. So I just use a probe. I don't use this probe. I use that long dentata spur and put it in there to see where I am. Now, tori. Taking out gigantic tori can be problematic because you don't want to cut through into the floor of the mouth. Now, what I used to do was lay a little flap and cut a groove in about through the torus blindly, and then take an osteotome and crack it off. And every once in a while you get a pretty good significant floor of the mouth bleed, and I've been involved with a fractured mandible. This is an easy way of making it predictable. This is a guy that came in with 2 tori that were touching in the midline, okay? And he came in with a wicked sequestra. Nobody to operate on him, and he'd been nursing this infection for about a month and was in a lot of pain. And I took this out with the technique I'm going to show you now, but it's so bloody that, I mean, it looks horrible. This is a really nasty mess. But it went really well, and he was really happy about how it came out. So we're going to do the other side, and I'm going to show you. I took my time to give you the plan, so you can see how large this thing is. The other one was just the same. What I do is I plan. I take a CBCT, and then I do what I always do. You map the arch, you map the nerve, and then I'm going to plan a series of small twist drills on the lingual based on where, and then I'm just going to connect the dots with a piezo, and then hit it once and peel it off. I know it's going to cleave right here, okay, right where the end of my drills are. Now, to figure out the angles here is while I'm drilling, since I don't have a guided piezo, I just take a twist drill and put it in the osteotomies, and then I can see my angles as I'm cutting her along. So I go ahead and I calibrate my handpiece, I calibrate my X-clip, and then I, make sure everything's properly calibrated. And then I have my implants, 30, 31, and 32, and I'm going to drill the osteotomies. So here we go. You're getting more videos because I'm using the Moravision a lot more now to take videos.
A mandibular lingual tori. To establish position, we'll cut the osteotomies with Lindemann burr. The ideal position is the blue dot, which is centered over this middle of the X point. And then the angle is indicated by the white circle, which we want to put over the top of the X spot, or the blue dot.
Doing system checks on
We've
the
just
bone.
switched to a different osteotomy, and we're going to be using a 2mm twist drill to go to depth. You can see in the bottom screens we're measuring the length of the burr. It says 41.4 millimeters in the bottom right screen. We're doing a quick system check. I just touched bone. I'm making sure it looks the same. Now I'm going to touch a tooth, and I see there's a little discrepancy, so I'm going to adjust the X-clip quickly just by rotating it on its long axis. And now we're going to start drilling to depth. And put it in its correct position. The blue dot is positioned in the center of the X guide. I'm going to then rotate up to the correct angle. Now I'm putting the white circle over the tip of the blue dot, centered over the X. And as I drill down, the color is indicated in the yellow until we get to the 45 degree on the clock, which is the ideal depth, in this case 13.3 millimeters, and when I get there it's going to turn green. If I went past it would turn red. So we just switched to a different osteotomy. Again, the blue dot over the center of the X point, the X point over the target. We correct the angle. Now we're drilling to depth. You can see this one is 13.7 millimeters deep. I've planned these osteotomies to where the curve of the cortical plates change from horizontal to vertical, and I'm drilling just below the depth of the cortical plate so I don't perforate into the floor of the mouth. We're about to hit depth. There we go, it's perfect. Now we're going to go to the final osteotomy, which is number 30. The staff selects the proper depth. We put the blue dot over the center of the X point. Get the correct position. We're drilling to depth.
You really see where the thorax and the horizontal meet.
Again, we're using the 2mm twist drill. In the center 2D images, you can see again that I've planned this to where the horizontal part of this torus meets the vertical part of the ascending or the body of the ramus, the cortices, and I'm doing another system check as I get down to the depth to make sure everything's tracking accurately. Don't want to perforate the floor of the mouth. I'm drilling down. When I hit the 45 degree on the clock, in this case 12.1 millimeters, it will go from yellow to green, and I'll know I've gone to depth. All right, we're done with the guided surgery, and now we're going to move to the piezo.
So what I'm doing here is I'm just connecting the dots, and in order to figure out the angle, I just put one of the twist drills in the osteotomy ahead of it, and then I can see my angle. Now these piezos only drill to 10 millimeters. That's as deep as you can drill with them. So I do that to that, and then I take an osteotome and hit it, and it peels right off. So here we go. And I show you this because I want to show you, this is where it meets, okay? The horizontal part meets right here. And you snap it, and it goes right down where you cut it. And you're not going to break a mandible when you do this way. All right? You don't see any perforations through anything. You stop right where we wanted to stop. Now this is distraction osteogenesis. Now if any of you have done this, if you do mandibles, the transport disc always wants to go lingual, because normally we cut through the entire thickness, right? We make two horizontal cuts and a vertical cut, and they go right through the entire thickness of the mandible. And then as you distract the transport disc up, the muscles pull it to the lingual. It happens every time. And we've tried ortho, we've tried all these things to stop it. And this is really the reason people stop doing it. In the maxilla, when you do it, the thick tissues of the palate pull it to the palate. Raj came up with this idea that he wasn't going to cut all the way through, and he was going to make an angle that would fight the distraction toward the lingual. You can see he's planned his osteotomies, just like you saw with the ridge splitting or with the torus removal. And then what's unique here is he plans not to cut all the way through, but he puts it on an angle. So this is his transport block out here, but he's cutting it at an angle so that as it wants to go this way, this angle is going to keep it to the buccal. And I think this is I've not done this. I used to do distraction, but I hated that problem. And most people did. And this is the first I've ever seen this. And again, he shared this with me, and I appreciate that. And let's see how he did. And there's the distraction transport disc. That's pretty amazing, I think. And it's where it belongs, to the buccal. Now, if he can reproduce this, and this works the way he showed it here, and somebody else can reproduce it, if I had a patient, I might try it. I think this might start falling back into favor again, because that's a really nice result. That's at 3 months. Now, this is really exciting. You know, before we started this whole project, I started getting involved with microscopes to see what we could do, and I went over and watched endodontists doing their endo and these micro endo approaches. And one of the problems is when they use a microscope is they got to pull it out of the way in order to use their drills. With guidance, you might not need to do that. But this is an endodontist in Lubbock, Texas, Charles Maupin, who puts in single tooth implants. That's all he does on the cases that he can't restore. And he decided, well, I have a hopeless tooth here. I can't get down these canals. He'll start drilling down and looking with a microscope, and he says it takes me an hour or two to do this. So he's planned an implant, just like we were doing a root shield. Now, the reason I believe that he actually is doing this, besides seeing his video, is because I do this all the time now for root shields. And instead of extracting that tooth I showed you before, I might say to my restorative doctors, I'll do the access endo and then send them over your favorite endodontist, and he could finish the case. So this is Maupin's case, and now you're going to watch him do it, and this is not edited. Now he's doing a system check now. Look at that. He's making sure he's right on that tooth. Now he's going to start drilling down. And the key here is the system check. You never trust the system, you verify. Trust and verify. And again, this is not edited. Now, this is something that used to take him 45 minutes to an hour. And you're going to see him, I believe he stops here and another system check. I'm not sure. All right, he's done. Now he's going to go to his microscope. And that's the finished case. And he's done many more of these, and they're accuracy studies. Now, one of the controversies in endo and why we get so many split teeth. How big is too big for a access opening for endo? And people are using microscopes so they can make smaller access openings. That is his access opening right there. And I said, well, how do you cleanse the teeth? He says, well, how do you cleanse the apex of a tooth? You put a file in, and then you put in peroxide, and that dissolves the tissues, right? And then he puts ultrasonics in there. He says, if you believe you can clean the tip of a tooth with fluid and peroxide or chloride, hypochlorite, and ultrasonic, why can't you do it up here? And so that is a controversial thing. I'm not going to even take a stance on it because I don't do endo. But they're starting to do these tiny little guided endo approaches. Now, Steve Buchanan has been printing little tiny guides. Steve Buchanan bought an X-guide. So he's working with Maupin now, and they've presented it at AAE, and they're the ones doing the accuracy study, and we have nothing to do with it. They're doing it on their own, and they're using his models. Have you ever seen his printed models for teaching? These 3D printed models that are amazing. And that's what they're using. So they're using it on model surgery. So, again, what I told you before is that this technology is not just for implants. It's starting with implants because there was a predicate device. But it's going to go further, and it's only based on your imagination. I've had people come up with me to talk to me tonight with some great ideas. And maybe you can extend them and do that, because this technology is in its infancy. So, guided surgery is more accurate and precise than freehand. You should guide all your implants placement. It doesn't matter whether it's both static guides and dynamic guidance are better. But dynamic guidance has unique indications and advantages. It's good for the same day, plan and guide. You can change your plan at any time. You can do anything like you're doing today, only you can see more. There's no lab necessary for a lot of the cases, especially when you have an intraoral scanner. You can do it on patients that can't open their mouth wide. And the cost, even compared to a lab-fabricated non-CAD guide, is less. And in the future, dynamic navigation's indications are going to grow as you figure out more things to do with it, because it's just a tool. So my thesis was guided surgery is more accurate, precise, and efficient than freehand, and that dynamic navigation is more efficient and versatile. It's the most efficient and versatile form of CAS. Does it improve your outcomes? Well, the evidence screams at you it does. Does it improve predictability? The evidence screams at you it does. Is it time efficient? If you follow our suggestions and guide all your simple cases at the beginning, you will become more efficient. It's easier than non-guiding. Okay. Does it decrease your costs? It does decrease your cost if you look at what you're spending now. It definitely does. So what are your obstacles? The obstacles are whatever you believe they are. So, what's your conclusions? You each have to come to your own conclusions, and I want you to go back to what Christensen said. What does the evidence say? And then you have to use your professional judgment. The biggest thanks I have to give, besides my wonderful hosts and our sponsors, these two wonderful, prestigious dental groups, is I have to thank all the docs that share patient care with me, because they're fantastic, and I'm a pleasure to work with them all. So thank you very much.
Thank you, Dr. Emery. You are our sunshine today. Thank you very much.
Thank you very much.
Thanks for the wonderful lecture.
Thank you. My pleasure.
最后我们有致赠感谢状，那我们再有请那个信昌生技总经理陈国师先生为我们颁发感谢状。So we will have a special certificate for Dr. Emery.
I appreciate the opportunity.
我们也感谢那个杨恩师。今天非常感谢各位的热情参与，相信经过 Dr. Emery 的介绍，大家对 guided surgery 和 navigation 有更深。
好，再张哦，来1、2、3 ，OK， 耶，
好，来举下。
好，来1、2、3，再张1、2、3。